By the end of a long psych shift, I'm struggling to remember what a patient said 6 hours ago, and patient seems off doesn't really hold up in a chart. So today I'm going to chart a full psych patient with you, start to finish, exactly the way I would do it. Quick heads up, this app was actually built by my stepdad, but it is genuinely what I use for my own charting. I am getting paid to talk about it, but I wouldn't be talking about it if I didn't think it was a really cool thing. Before we get started, I just want to talk a little bit about why psych documentation matters. Not only does it guide treatment and support continuity of care, but it also protects your license. The part that actually protects you is the safety assessment at the end, so stick around for that. So today our fictional patient is going to be a 47-year-old male named Daniel, who voluntarily came to the inpatient psychiatric unit after telling his primary care provider he'd been feeling increasingly depressed over the last few weeks following a job loss. He says things like, "I wish I just wouldn't wake up." He isn't reporting a suicide attempt, and at admission, he denied having a plan, access to means, or intent, but he has endorsed passive suicidal thoughts, as said before. He's here for medication, adjustment, stabilization, and safety monitoring. And we're going to say this is hospital day 2. So whenever I start a psych documentation, I always really work the same way. So we're going to start with environment and status, and we're going to say our patient is awake. He's in his room though, he has not been attending groups, and he appears to be resting right now. And if he was having another activity, I could put that there. And we can put some additional observations. So he's sitting, slumped in chair, minimal, minimal movement, appears tired. And this is nothing judgmental, this is just exactly what I'm seeing. So I have that here, so I'm gonna move on to my next section. So mood and affect, this is actually one of the biggest mistakes I see and I have made before myself. Mood and affect are similar, but they're not the same thing. Mood is what a patient tells me. So if Daniel says, "I just feel like a burden," that would be his mood. That would be like he's feeling depressed. Affect is what I observe. So that's maybe he has very little facial expression, he's tearful, things like that. So we can say his mood is, it's pretty clear he's feeling depressed, and that his affect is flat. Again, I could put something else in here, so I could say, patient stated, "I just feel like a burden." So we have that here. Next, we're moving on to our thought process. So, just because he is depressed does not mean his thought process is impaired. So we're gonna say his thought process right now is clear, linear, and organized. He's just having some issues with his mental status. He has no flight of ideas, no tangential speech, nothing bizarre. So I document exactly that. And we can say that his next up is behavior. So he did stay in his room through breakfast. He declined group therapy. He's mostly answering with one-word questions. Again, these are behaviors I actually observed, not interpretations. So we can say he's a bit withdrawn. So we can say exactly that. He's refused breakfast, declined group therapy. Mostly one-word responses. Got that here, so we'll move on. So this is the important part. This is our safety assessment, safety screening. This is the section I spend the most time on. So first of all, we have our suicide and behavior flags. Basically, are there anything right now that is pointing towards a potential suicide attempt, or have they had one in the past? Because we're having passive ideation, that's not technically a suicide flag at the moment. We are going to put yes for the suicidal ideation because he did mention that. And a behavioral flag is basically like, are they agitated? Are they irritable? Are they maybe getting a little bit aggressive? Things like that. And we're also having no homicidal ideation and no hallucinations presently. And his safety plan is current because he has been here for 2 days. Alright, so he is positive for suicidal ideation. So it's really important that we note that it was passive. So we're not having active suicidal ideation, we're having passive suicidal ideation. And whenever you have suicidal ideation in general, you always want to ask these questions. Do you have a plan? Do you have access to means? And do you have intent to act on these thoughts? So we know that he does not have a plan, he does not have access to means, and he does not have any intent to act on these thoughts. So we'll just say that we have safety plan was reviewed just to make sure, his provider was notified, medication was given, and there was some therapeutic interventions. We'll say that he agreed to notify staff if thoughts become worse. Right? And he was also very cooperative. All right, so speech is usually pretty straightforward here. We can say he's taking a long time to answer questions. He speaks slowly. He has long pauses before responding. These are objective observations. So we can say it's a little limited and he's a bit withdrawn. And we can also say he's speaking, just like I said, speaking slowly, long pauses. We can say that, long pauses. And it's whenever you can, it's really important to just add some extra details just so you have that to fall back on if your chart is ever reviewed. Move on to next. So as his activities of daily living. So we could say that Mr. Daniel is independent. He is able to do his own, but maybe he's not right now, just because he is having a bit of a rough time. So we can say he's not attending to those right now. But he doesn't have any physical limitations. So his gait is steady and he's ambulating pretty easily. He has some limited intake with his eating and drinking, and he did refuse his breakfast. So we can say that refused breakfast. And he also refused groups. So next we have our medication compliance. And I'm also noting that his sertraline was increased yesterday from 50 to 100 milligrams because medication changes matter for whoever takes it next. So I'll say he was compliant. He took all his medications. He doesn't have any medical issues. His commitment status was voluntary, as we said, and he's not having any other medical issues. And we can say that his sertraline was increased. Thing does not like me spelling. Sertraline increased from 50 mg to 100 mg. So we got that there. And then last we have our disposition. So we are always trying to make sure that we are headed towards just whatever is best for after we're done with them in the psych unit. So we'll say that we're continuing to explore options for discharge. We're not sure if he needs to, be somewhere where if our suicidal ideation is going to move from passive to active. So we're still exploring that, and we can put anything extra there. So he denies. We have any closing options we can add, custom closing, and we'll continue his 15-minute safety checks. And then that is basically all. So I'm going to click continue to review. I can make sure all this information is correct. I'm happy with it, and then I can generate a narrative. So this is basically going to take all the information that we had and move it into a nice, beautiful narrative. So it saves me a lot of time, and so I can continue to look in on my patients and make sure everything's good, so I'm not stuck at the computer all the time. So some key takeaways for psych charting is you always want to be objective, accurate, specific, and timely. Again, that supports the continuity of care and helps towards treatment plan. This is probably my biggest tip. Whenever you're charting psych patients, ask yourself one question. Is this something I observed or something the patient told me? If it's something they told you, use quotes whenever possible. That is so useful to fall back on because there's no room for misinterpretation because you're just putting exactly what you heard. If it's something you observed, then you describe the behavior. That's objective. So I have while we were talking, we got my narrative all done. So I can add if I need to, I can remove if I need to, but if I'm all good, I can save the narrative. And that's how I chart this entire psych assessment. Notice that everything in this note is either something I directly observed or something the patient said in his own words. That protects both your patient and your nursing license and your hospital as a whole. If you'd like another if you'd like another psych charting walkthrough, next we're doing a patient experiencing command hallucinations. So make sure you're subscribed, and I'll see you in the next one. Thank you.